Pahl, Chief Exec of the. Good afternoon, everyone. I'm Nick Pahl, Chief Exec of the Society of Occupational Medicine. Welcome to this launch of the value proposition, the revised Occupational Health value proposition. In the chat, you can see the document itself, and Pahl Nicholson, who's the author of the report, who's worked extremely hard with partners with Australia and New Zealand to revise this document. And there's a survey there, which I've also posted in terms of how it's been a value up to now. It's launched back in 2017. And there's various leaflets that are also being launched along with this. So do complete that survey. In terms of the schedule for today, welcome one and all, obviously. We've got Pahl Nicholson, who's going to do a recorded presentation, but he is here and, I'm sure willing to be part of discussion and questions at the end. And talking about, we did a value proposition report for research. So we will have presentation from him. And then hopefully we will then flip over to Australia and Dr. Mary O'Bailey, who we're very pleased to have this new partnership with the Australians and New Zealanders on this, and they see this value, and I think other countries around the world too, like Ireland. So unfortunately, there's apologies from WHO. Ivan Ivanov is feeling a bit poorly, and he's going to take the rest of the week off. And I think a lot of people are feeling a bit like that, and certainly Carol Black sent me a message and hoping she would join us, but there is COVID going around, or people just getting colds and flus as they've kind of come out of isolation and met people and picked up things. So apologies about that, but plenty of time for discussion, and we'll end at 1:30, if not before. I mean, in terms of the Occupational Health Value Proposition document itself, as I said, it was first published in 2017 by SOM, written and authored by Dr. Pahl Nicholson, who did an incredible amount of work looking at the evidence base for occupational health and showing what value it had. And then we had an approach by the Australian New Zealand SOM and the faculty who wanted to do a local version, and that led to a speeding up in terms of the both the collaboration and also our kind of relaunch of this. And it's been launched on the Creative Commons license, so anyone you can use this, build on this material for your own use, and that's the point of it, isn't it? Is that we make the case for and make the case of the value of occupational health to business, to governments, to health services. We're also pleased that Lord Blunkett, David Blunkett, our patron, has endorsed it, and there's a nice little forward in the report and saying why it's good in terms of the recruitment retention, particularly for health services at the moment, who've obviously had a very tough time with the pandemic. And also, I think in terms of our call for universal access to occupational health, this is important. We're really keen that the UK government delivers on its Health as Everyone's Business consultation, which looks at investing in occupational health for a Centre for Work and Health, which I'm sure Ewan will talk about, developing the research base, but also delivery, investing in the workforce. And we've been talking to chief medical officers around the UK on this, and workforce leads, and just showing the benefit of it. And yesterday we had a really good afternoon on long COVID return to work, and we know occupational health has real value in a sort of newly emerging area, and certainly we're seeing occupational health involved in that in England at least. Just in terms of Mary O'Bailey, and she's consultant occupational environmental physician and fellow of the Australasian Faculty of Occupational Environmental Medicine. She's also keen to talk about how in Australia and New Zealand they're doing their best to promote good work, safe workplaces, healthy workers, and getting recognised as a big challenge, and this collaboration helps with that. And I know Jane Moore, the SOM president, is really pleased to see how the evidence base has been brought together, and really a huge thanks to Pahl, who has worked incredibly hard in a very rigorous way, actually, and evidence base and the rigor is key to this. So a big thanks to him, and it's nice to see other people in the audience, from Rory O'Neill from International Trade Union Movement to Dr. Richard Heron. So many of you are real experts in this area too, and putting it into practice. So I can see Owen Tudor too, actually, and there's been a huge push actually in the ILO, International Labour, some success recently in terms of putting occupational health as a kind of workers' right, and we're hoping that's going to be signed off in what sort of June time. I think it's been sort of approved. And you can see I'm a bit shaky on the detail. I'm sure Owen and Rory can update us, which is, you know, hats off to them. Huge work at that global level to make sure occupational health is seen as value, but also with WHO pushing across the world. You know, it's really important that it's not only just in the UK, but there's sort of global push on that. Okay, I can see on the chat people want to see the report and it's been reposted, so do use that. But I think enough from me, and I'm going to hand over to Pahl Nicholson, who's with his recorded presentation. Recorded because I think he just really wanted to be clear on what the messages were, and no room for doubt on that. And so over to Nick, who's going to be our tech wizard, but I know Paul's in the background in case there's any problems.
Thank you for attending this presentation to launch the new edition of Occupational Health, the Value Proposition. During this presentation, I shall look at the reasons why we update the report now, what has and what hasn't changed since 2017. I will expose some myths, naivety, and noble lies, looking in particular at well-being and health promotion, and then close with some key points and suggested next steps. So why did we update the report other than it is good practice? Well, it proved to be very timely. At the end of 2021, the UK government published its response to the consultation, Health is Everyone's Business, which included a renewed focus on occupational health. The Australian and New Zealand Society of Occupational Medicine intended to produce an Australian value proposition in March of 2022, and therefore it made sense to update the evidence review in time for that. And admittedly, in hindsight, the updated report might help to inform the update of the faculty SECRO standards that are due out at the end of the year. Then there are the ongoing challenges of aging workforces, including the aging of our own specialty and the drain of qualified resources through retirement. Aging populations increase the burden of long-term health conditions and the need for support from occupational health when access to occupational health is low and currently only likely to get worse. Finally, there are a few evolving trends, such as the gig economy, with people having precarious employment through non-standard job contracts, and the growth of home and hybrid working due to technology and post-COVID. And then there's the ever-present risk of yet another public health emergency. Now, what has and hasn't changed? Well, let's look at what's the same. The general messages are unchanged, and the new evidence simply adds weight to those. It continues to be the case that primary research is generally of low quality, and there still remains difficulty in monetizing intangible benefits and the costs of presenteeism. It remains the case that employers provide occupational health for a combination of legal, moral, and financial reasons, and the single key message is unchanged. That is, occupational health services improve employee health, workforce productivity, organizational performance, and the economy. As to what's new, well, the chapter's been rearranged. The explanation of what occupational health does is being brought forward from the appendices, and there's a new foreword written by Lord Blunkett. We have also decided to issue the report using a Creative Commons license, so that not only can ANSOM use material, but anyone else can free of charge. Some old reports excluded from the 2017 value proposition have been added in order to expose and bust myths. The new evidence has been added right up to the 28th of February this year. 130 of the 224 references are new, as are 64 of the 106 systematic reviews that are included. And with regard to the updated text and key points, more than 7,000 words out of more than 15,000 are new. So this is a significant review. Well, it isn't just new evidence that's been added to the report. Some old reports have been added as well, with the single purpose of exposing and busting some myths. And these relate to access to occupational health and the return on investment that is purported to result from workplace health promotion interventions. And to adapt a quote from Arthur Jones, the organizational design expert, all studies are perfectly designed to get the results that they get. Now, the first myth to bust relates to employee access to occupational health services. The problem here is that government and subsequently professional bodies cite the latest evidence as fact without considering the study design and the body of evidence. A recent government report stated that about half of the workforce could access occupational health based on firstly two experts' opinions, and also a telephone survey conducted for the Department of Work and Pensions back in 2015. So let's look at that telephone survey and its previous one. Now, data from 2010 indicated that 38% of employees could access occupational health. When repeated in 2014, the survey indicated that an increased amount, 51% of employees could access occupational health. But there was a lack of internal consistency, because when the same questions were asked of 358 employees who'd been off sick for more than 2 weeks, 37% would not use fitness to work because they already had access to an occupational health service. Now you'll see that there's a close similarity between that subgroup analysis and the 2010 survey. So why this discrepancy of 51% against 37 and 38%? Well, going back to the Arthur Jones quote, they got the results the design permits. The only significant difference between the 2010 and 2014 studies, apart from the different respondents, was how occupational health was defined. You can see that in 2010, occupational health wasn't defined at all, but in 2014, it was defined as providing advice and practical support about how to stay healthy in the workplace and how to manage health conditions. Perhaps something more akin to health promotion, and potentially could be supplied by various resources. So let's revisit history to see how definitions of occupational health affect results that studies get. 20 years ago, Adele Pilkington and colleagues at the IOM examined the impact of definitions and employers' understanding of occupational health. When defining occupational health broadly, that is to say, hazard identification, risk management, and provision of information, which is really what health and safety does, 19% of surveyed employers believe they provided occupational health support. But using a stringent definition by adding specific duties, including modifying work activities, providing occupational health related training, and monitoring health trends, only 3.3% of surveyed employers said that they provided occupational health support. Now, Adele also demonstrated employers' lack of understanding of the meaning of occupational health support and who could provide it. Employers reporting that it was provided by employees with health and safety training in 48% of cases, by employees without any such training in a quarter of cases or thereabouts, and in 7% of cases by first aiders. So this is an important paper not to be forgotten over time. Among the latest evidence is a report from the DWP published in 2020. In this survey of private occupational health providers, 44% said they were unable to fill occupational health nurse or physician vacancies due to the lack of suitably trained candidates, and consequently 53% have been forced to decline work. Now, this seems to indicate that the problem goes much further than employers either being unwilling to pay for occupational health services or wanting to see evidence of a return on investment prior to commissioning services. The lessons here seem to be that we need reliable and reproducible data regarding employee access to occupational health services. We must acknowledge that overestimating access diminishes the sense of urgency to put things right. We need to communicate more widely what it is that occupational health does, particularly its distinctive competencies. And we need to close the capability and capacity gaps with some urgency, bearing in mind the socio-demographic challenges mentioned earlier. Now to well-being and health promotion. Is conversation about this in one slide a basket of apples and oranges? Once upon a time, the debate used to be whether or not well-being was hyphenated. Now we seem to conflate well-being and health promotion, and probably understandably, because it means different things to people with different professional backgrounds. There is plenty of evidence to suggest that well-being is associated with diverse outcomes, including job satisfaction, employee engagement, retention, productivity, morale, and so on. But well-being is a people and performance strategy. It is not an occupational health program. And that's because well-being is multifactorial. Its determinants at work include factors such as career satisfaction, career development, reward, characteristics of the job such as autonomy, clarity, variety, the working environment such as hazards in the workplace and job security, work organisation, working hours, whether or not there is effective supervision, social determinants such as culture, values and support, whereas health and health promotion are only a small contributor to employee health and well-being. You might glean from the number of studies published at the foot of this slide that health promotion has attracted more research than almost anything else that occupational health does. And what the latest evidence continues to show is that the popularity and commercial interest in workplace health promotion is not backed by good quality evidence for efficacy, effectiveness, or cost effectiveness. Systematic reviews report that only around 1 in 4 primary studies are of high quality, and that the return on investment is inversely related to study quality, control studies being likely to report either null or negative ROI. Now, even among systematic reviews, only about 20 to 40% of those are of high quality, so they often reach different conclusions depending on the methodologies used. And meta-analyses too produce mixed results for benefits related to the costs of health promotion interventions. The updated report includes 2 old publications that were rejected when writing the first edition. This is because these publications are still being cited inappropriately. First of all, the PwC report, Building the Case for Wellness. Among 55 unpublished and therefore non-peer-reviewed case studies, 7 estimated ROI with a range from parity to 34 to 1. This report is cited widely on websites such as those providers of corporate training and corporate yoga as a review of 7 wellbeing programs suggested the average benefit cost ratio was £4.17 for every pound spent. Well, it wasn't an average, but just one of 7 examples. As I mentioned, none of the studies were peer-reviewed, and this study used perceived costs and perceived benefits. But importantly, it related very specifically to revised manual handling training for any well-being intervention. In what is widely referred to as the Harvard study, and taken at face value because it comes from an Ivy League university, is the myth that for every dollar spent on wellness programs, medical costs fall by about $3.27 and absenteeism costs fall by about $2.73. The facts are that the meta-analysis only included 1 study for any 1 intervention, thus excluding evidence from similar studies. Some studies were old and dated as far back as the 1980s. Of the 22 studies contributing to the meta-analysis, 13 were uncontrolled studies and therefore below quality. 7 used assumed costs, and studies included motivated volunteers causing selection bias. Several also utilise low-cost interventions such as self-help and health risk appraisals that would increase the chance of reporting positive ROI. Despite the authors cautioning against generalising the results and criticism by other study authors, it continues to be cited as evidence without any attempted critical appraisal by those who continue to cite it. The last 3 years has provided high-quality evidence regarding workplace health promotion interventions. This comes from 2 large cluster randomized trials. Firstly, the Illinois Workplace Wellness Study. This observed no effects on medical expenditures, employee productivity, and self-reported health status after more than 2 years. Employees who participated already had healthier behaviours and lower healthcare spending compared with non-participants. The authors, in looking at previous research, concluded that 84% of medical expenditure and absenteeism estimates were unreliable, and mostly because of selection bias. Now, the authors of the 2010 Harvard study, in their cluster randomized trial, reported that there were no significant differences in healthcare spending or in absenteeism costs at either 18 months or 3 years of follow-up, and that these findings may temper expectations about the financial return on investment that wellness programs can deliver in the short term. Again, they noted too that most prior studies were based on observational designs, and these had methodological flaws, and again, in particular, selection bias. Writing in the Washington Post, the authors of the Harvard study stated, "Workplace wellness programs are big business, but they might not work." Now, another new large study has evidenced the effect of selection bias. It's not unusual for employers to measure the success of their workplace health promotion programs by comparing employee survey scores for those who do and those who do not participate. An association is not uncommon, but it isn't a causation. In a retrospective study of more than 10,000 employees who were followed up for 3 years, the authors noted that most participants had better scores for job satisfaction and intention to stay, but that these effects disappeared when controlling for pre-intervention scores. So what does this mean? Well, it really depends on what employers are trying to achieve. If they are seeking to add benefits that they believe that workers value, or they want to attract the type of workers who value those benefits, then workplace health promotion programs may be worth doing. But if the goal is to save money by reducing healthcare costs and absenteeism costs, or to improve long-term health conditions, well, I'm afraid there is very little evidence of effectiveness. So, occupational health professionals must critically appraise studies before naively incorporating low-quality evidence into practice. And for organisations, they must avoid noble lies, that is to say, adopting myths simply to advance their own agendas. Now, in terms of more core occupational health work, the strongest evidence for economic return is in relation to return to work interventions. Cross-sectional studies have benefit of earlier referral for cases of long-term sickness absence, and evidence supports restricting post-offer health assessments to job-specific examinations, provided that the tests provided have positive predictive validity. In terms of legally mandated interventions such as health surveillance, these are rarely evaluated for either effectiveness or cost effectiveness, and specific research might well be worth undertaking. With regard to pre-placement health assessments, previous systematic reviews have found little, no, or inconsistent evidence that these were effective in determining future health or occupational outcomes. New studies have demonstrated, firstly through a systematic review, that pre-employment or post-offer personality assessments are of low utility in predicting common mental disorders among emergency workers, and the same authors in a prospective study evidence that there was no association between validated pre-employment measures of personality and psychopathology with mental health outcomes amongst Australian police officers, even in their first 7 years of employment. For long-term sickness absence management, previous intervention studies in English and Scottish hospitals in Southampton and Lanarkshire demonstrated that earlier referrals to occupational health and intensive case management and a biopsychosocial approach reduced sickness absences and were cost effective. The Scottish study estimated return on investment to be 1.56 to 1. There is now evidence from a large Canadian healthcare employer that had 29 hospitals and which strengthened its disability management program, placing emphasis on early contact, supervisor training, and involving union representatives in return to work planning. Over the course of 6 years, it achieved larger reductions in disability durations in the intervention group, a mean of 8.5 days, compared to the comparison group in which the disability duration was reduced only by a mean of 3 days. Now, while the evidence is provided and the report argues for the value proposition for occupational health, there is a very important caveat, and that is that not all occupational health services are equal. This is demonstrated by a recent HSE prosecution wherein a company was fined for causing several cases of hand-on vibration syndrome, something which is only detected after they changed their occupational health provider, the previous provider failing to provide suitable health surveillance. For these reasons, the updated report emphasises that each occupational health service should demonstrate its own value, and data from the value proposition report should not be generalised to all services. Fortunately, increasingly occupational health services are having to demonstrate value and to make the business case for their own services. Evidence from the USA shows that all nurses who responded to a survey considered this to be essential to the profession and for ensuring the quality of their own services. In the UK, occupational health professionals who were surveyed consider that cost-benefit analyses are a very important area for future research, and 2/3 of occupational health providers who were surveyed already capture outcome data, and most of those found it to be useful to demonstrate effectiveness to their customers. The report continues to propose that the key benefits of occupational health to employees are to improve health, maintain workability, and maintain earnings. To workforces, to reduce absenteeism, reduce presenteeism, and improve productivity. To employers, to improve performance, lower costs, and increase profits. And to the economy, to reduce the costs of healthcare and benefits, to increase tax and national insurance revenues, and to improve GDP. Now, a few key points in closing. Moral reasons, or the right thing to do, outweigh legal and financial reasons for employers to provide access to occupational health. Employers should accept that most health interventions come at a cost, and that expectations for return on investment may be unrealistic. Occupational health business cases should reflect value and intangible benefits rather than ROI, and what matters is to determine the most cost-effective ways to deliver care, that is to say, value for money. Finally, some requested next steps. Please integrate the evidence into practice, help share the evidence, and complete the 1-minute survey to allow us to decide whether or not to update the accompanying lay leaflets. Thank you for listening.
Right. Well, thanks, Paul. At least automated Paul. I think that's very, very clear, wasn't it, about where the ROI sits and some of the problems with the studies, which is why it's good to have Ewan here to talk about, future research and the research capacity issue we've got. At 12:30, we do have some time if there's any particular questions or comments. a lot of experts in the field, from Nerys Williams, who's on the UEMS, the sort of European Occupational Medicine Society grouping, also Paul Litchfield, my strategic advisor, Christine Polter, educationists like Linda Bruce, Richard Heron, working globally. Any comments or thoughts on that? I mean, it's a very realistic report, isn't it? It's not over-egging it, it's evidence-based. I'll be clear about sort of pre-employment side, for example, that there's not an evidence base there, but it's clear ROI in other areas. So any comments or thoughts? You're stunned into silence. Sorry about my munching my sandwiches whilst this report went on. I couldn't help myself. Christine.
Yeah, oh, I'm just trying to start my video. I see I'm having my usual problem. I'm sorry. Can you hear me okay?
Yeah, I can hear you.
Yeah, I woke up, unfortunately. So my concern is on ROI, because it's not required for things like pensions or holidays. And so I just wonder why we have to remain so focused on proving the monetary value of investing in Occ Health when it's not required for other things that are deemed essential.
Well, let's talk to the people in corporate world. I know Richard Heron or Paul, I know you had to do that when you're talking to the board, but yeah. Richard, you know, in BP, I imagine ROI is a pretty standard thing, isn't it?
Well, surprisingly, I would say less than you might imagine. I think it is a value proposition rather than purely a dollar piece. And I wouldn't underestimate the value of demonstrable care about employees that comes with having an occupational health service that is valued, and probably also from some of the well-being environment that's around it. I think the big question is how to make the report change attitudes and behaviours, because it's a fantastic report and a great piece of work, Paul. It's really fantastic. And I think the challenge that you find in organisations is localising the data that's in a big report, making it very, very relevant to a particular employer, that particular employer. So, I take Paul's big point around some of the studies on retention and employee surveys. What I would say with those is even showing strong correlation has a pull for investment in health services within an organisation. So if you're seeing correlations between organisations or pieces of an organisation where they invest in the line manager care proposition, you see better sickness absence, you see better accident rates, you see better ethical performance. And of course, that goes without saying, because you're seeing better management in practice. I don't think you can prove that it's directly down to the occupational health intervention. It's a culture shift, and taken together, it makes sense.
Yes, I mean, and culture and values are a very big influence. And I mean, the focus of the report, just going back to Christine's point, is that we should be encouraging more and more people to think exactly about value and try to dissuade as many employers and commissioners of services as possible to stop thinking and stop looking for a financial ROI.
Yeah, John Ballard, have you got any comments?
I do actually, but I've just got a delivery. Can I come back in 2 seconds? It's our journal coming for the printers. I've just heard the doorbell.
Okay. I thought it was Sainsbury's for a moment.
I might just add, Nick. While John's getting the doorbell, I think it's very dangerous to go off ROIs that are based on woolly data or US healthcare cost data in the UK. Full stop. Any attempt to try and out CFO a CFO, talking about conversions to earnings before share, EBITDA, and all of this stuff, is actually seen as smoke and mirrors, and is transparently unpickable straight away. So I think it's very dangerous for people to try and use that as a surrogate for speaking business language. It isn't speaking business language. Business language is actually understanding the context that the business is in, applying an intervention that helps the business to be more successful. And I think I would focus much more on that. I think Owen's asking to come in as well.
Yeah, Owen, thanks.
Sorry, I was struck by John Ballard's flagrant attempt to gain publicity for his journal by announcing its arrival. I thought that was classic from John. Thanks for that, John. Long time. Now, I was going to say on ROIs. I mean, this is a slightly cynical point of view from a trade union background, obviously, but our experience very often was that corporate decision makers very often needed the ROI to justify a decision that they knew they needed to take. It wasn't so much that they would take the decision solely on the ROI, but they wanted the ROI figures so they could justify to other people who didn't necessarily know what they were arguing for that this was the right decision to take. I'd only reflect as well. I know cost benefit assessment has come on in the years since, but a senior HSE official told me that when they did the cost benefit analysis on the display screen equipment regulations, which is, I realise, going back a long way, they actually later, they found that the cost benefit assessment showed that the regulations were the right thing to do. They then went back a few years later and tested the assumptions that had been made under the CBA, found they were all entirely bogus, hadn't actually come to pass, went back and asked the people involved if they'd known the real figures, would they have taken a different decision, and they all said no, suggesting that there isn't quite so much business rationality involved in this process as there might be. On the other hand, we very often ourselves use those ROI arguments, and but also in terms of explaining the benefit of occupational health and safety to governments in terms of what will have, what has an impact on their health services and things like that, because some people need that comfort blanket. And since the figures almost always come out the right way on a lot of these things, sort of the moral objections that we have to equating, to making a judgment between human life and cost. Sometimes we just have to be pragmatic about those things.
Yeah. Okay, so I'm going to go to, is it Dr. Talani, and then to John Ballard after that. So Dr. Talani, you got your hand up.
Yeah, I'm just going on from what Richard was saying about looking at the dollar piece. I think one of the conclusions from this report was looking at the intangibles versus the tangibles. And I think Richard is absolutely on, particularly in the oil industry, there is evidence for the intangibles. And if you look at it in business speak, we'll talk about soft skills versus hard skills. Now, those soft skills sometimes are not easily measurable, but they do play an important role. We've just come out of the back of COVID, and most organizations, even if it's just from a soft skill or an intangible measure, will say occupational health has proved its worth. But the critical piece for me is the quality of occupational health delivery. And if we're going to be strict, then we need to really critique that aspect of delivery, because if we're not giving the value for money, then we're doing our organizations a disservice. So it's really value for money rather than dollar return on investment. That's of the points I think one needs to make very clearly.
Yeah, that's nicely said. Okay, over to John Ballard and then Malaki Abba.
Okay, thank you very much. Sorry about being interrupted by the printers, but anyway, I've got our journal safely here. Now, there's a couple of things. I mean, first of all, I think Paul's done a terrific job, and I echo pretty much everything he says in that report. But there's 2 points I wanted to make. First of all, that if you're looking at any kind of health intervention, you're really looking at cost effectiveness rather than return on investment. You establish that you need to do something, whether that's for moral, legal, practical reasons, and it's about looking for the way of doing that and achieving the best value for money. It's not trying to say that if we invest £1, we're going to get £3 back. because that is very, very difficult to prove in any area of health. And I wanted to draw your attention to the study that was done, commissioned by the DWP, in fact, when they did the Stevenson Pharma review of mental health. And this was trying to establish why employers should be doing more to invest in mental health for employees. And Deloitte presumably paid an enormous amount of money to do this research. They found what they called a systematic review, but I don't think it's what the rest of us would call a systematic review. And they said that they found a return on investment of £4.20 for every £1 spent on mental health interventions in the workplace. And they said this was based on 23 reliable reports. And that's a direct quote from their study. And in fact, they claimed that they were primary sources. But in fact, when I actually looked at the references, they weren't primary sources at all. Most of them were referring to each other. And in the end, there was only one scientific study that was the foundation for all of these. Quality research. And it's as if Deloitte had been told you have to find a return on investment. And it's virtually impossible to do. The evidence is non-existent. And actually, we should be asking the question, as I think has been raised by a couple of people this morning, to say, well, why do we need a return on investment? And it's no point in saying, well, for pragmatic reasons, we should be trying to find it because it's persuasive. It's actually dishonest to do that because we know the evidence isn't there. But what we do know is that if there's a way of, for example, in that case, trying to improve the mental health of the workplace, there might be half a dozen different interventions. Let's look at the one that gives us the most effectiveness for the money that we're spending on it.
Yeah.
So I think, as Paul has said throughout the report, it's cost effectiveness, not return on investment, which is key.
Yeah, thank you. That's well said, John.
Okay. Equally, that you try to find the evidence for return on investment, it just is not there.
Yeah. Okay, thanks, John. I'm going to pass over to Malachy, and then Paul, if you want to spend a minute just wrapping up, and then we'll go over to Ewan. So Malachy, what's your comment?
Yes, thanks very much, Paul, for the presentation. That was very good. I think everyone here seems to be going towards the direction that the evidence for ROI probably is non-existent, if at all anything. And I just wanted to, make a comment to what Owen has said. Should we really be making a value proposition to companies? Companies being what they are, businesses, they will always focus on return on investment, regardless of however you look at it. They are there to make profit. And if the numbers doesn't add up, then it's either that they have a lot of money for PR purposes or, for, sort of a corporate responsibility thing. But not all companies do have such a financial manpower. And perhaps it might be time we shifted making this case to the government itself, saying, well, look, the amount of money that, health interventions or what the NHS is shouldering because of, the employers are not providing these services is quite enormous. So we could actually shift the value proposition away from companies and then direct that to the government because probably the government is spending quite a lot on that aspect.
No, that's for sure. Well, I know the Work and Health Unit are here, and frankly, I'm quite concerned about whether, for example, the NHS growing occupational health program is going to be funded, and hopefully people who are involved here today might push that. Certainly we've been pushing it, but thanks, Malachy. So Paul, any final comments before we go over to you and talk about research?
No, just to be very, very quick, I think that from the feedback and the comments so far, it's clear that we are preaching to the converted with the audience today. I think out in the world of work, obviously employers are a mixed bag. There are those, particularly large multinationals, which do think about value and the health and overall well-being of their employees, and it's delivered through a multitude of different people, through HR, for example. And then in the UK, I think particularly among small and medium-sized enterprises, many of those complain that they just can't afford occupational health. And I think it's among those that they particularly want to see an ROI. But to reinforce what was in the report and from some of the comments this morning, the important thing is about cost effectiveness, delivering and improving that value for money. And again, just trying to educate more people to think less about that financial ROI. And I think beyond this report, examples of best practice from among our own colleagues of how do they go around demonstrating value to their own customers. And that might be just as much use as examining the data that's in the journals.
Yeah, well said. Okay, so I'm going to move things on to that research. Nice segue. I'm going to drive your slides for you, Ewan. So over to Professor Ewan Macdonald, who's going to talk about the value of occupational health research.
Thank you very much. And I enjoyed Paul's analysis and presentation very much. Could you go back to the first slide, please? Yeah, the value of occupational health was a study which was commissioned by, and a report commissioned by SOM and published in June 2017. And so when people ask me about value, what do we mean by it? So next slide. And so I like to tell this story that no one has ever bought me a pint in a pub when I tell them I'm an occupational physician. And whereas if I was a neurosurgeon, I suspect I'd be inundated with free drinks. After showing you all this slide, I expect to be overwhelmed by people wanting to buy me my first drink. But I haven't been in a pub for the last 2 years. I'm not sure when the opportunity will arise. So next slide, please. So the team that I assembled to do this, and it was quite a short commission, and Nick had to persuade me to do it, and then we got to move quite fast. And so my colleague Dushka Lalo, Sergio, Varga Prada, Figuero, both consultant occupational physicians and active researchers. What I also introduced was social qualitative research, and Evie Germany is sort of absolutely leading qualitative researcher working for the Health Economic and Health Technology Assessment Group, who are next door to me in the University of Glasgow, except they're about 40 strong, and I'm very much less, being occupational health. And also Professor Emma McIntosh, Professor of Health Economics, these people right at the top of their game in health economics. And to persuade them to get involved in this, because there was almost no funding for them, and that's very unusual for health economists to work for goodwill, but persuade them, and their impact was quite significant. So part of our report was on the health economics. Now, don't expect me to debate health economics, because as soon as you start talking to health economists and economists, and the kind of language we use is really larded with ignorance, really, in what really is meant. So I'm not going to, I'll present their observations, but I can't debate. I agree with the last point made in the last presentation, that in fact, this problem with research is the amount of, lots of problems with research, which we all know. The time it takes to set up, getting control groups, it takes years to do, lots of constraints. Meanwhile, people out in the field are tackling issues such as £1 million a year in the health board when I first went there, and compensation for low back pain. So we eliminated manual handling, and 10 years later the costs were 100,000 a year. Now that kind of thing doesn't get written up because it's not a study. So, and all my colleagues have got stories like that. Next slide, please. So I had a very expert team, and this is the process. The process was defining it, historical background, evolution of work. You can read all this. Developments, the burden of health on work and work-related ill health, establishing health priorities, resourcing, translation of research into policy and practice, definition of value, scoping review of the economic valuation of workplace interventions. So this was the economists looking at doing a review with our help of the publications of workplace interventions. Stakeholder perspectives as well, qualitatively, discussion and conclusion. So that's the structure of the report. I'm reading it again recently. Like Paul's document, these are very good reads because they get right to the heart of what we're doing. Next slide, please. So defining, there's lots of definitions of occupational health, and there's various ones used in the report, but it's about improving health, well-being and functional capability of the working age population. Well, the problem with well-being is it's a term that I share all the views that it means to people what they think it means to them, but it's for example, in the Healthy Working Lives strategy for Scotland, people can't get an award if they just do a health promotion activity. They have to be linking it to health and safety and health and safety and OH interventions. That was something that became very clear to me after seeing an organisation get a gold award for their health promotion programme, but meanwhile someone had got their hand cut off in a factory. So you couldn't get an award unless you were proving the whole round, and that's the Scottish approach to the national award system, which is on hold at the moment post-COVID. Discussing the evolution, it's protection, it's promotion, function, psychosocial, economic, and aging. Aging is probably the biggest issue that's facing us now, and that provides scientific challenge, and also it's very important. The burden of health and work-related ill health, establishing research priorities. We've recently published on that with colleagues, and so the last paper we did on this was economics. The economics, disability management, occupational disease, injury and illness, with a sort of hierarchy of importance, and that was surveying OH people. The qualitative interviews were extremely useful. I gave a list of names, and I don't know who was interviewed, but they were really extremely useful. Definition of value, well, the 4% figure of GDP was endorsed by our economists. And if it's 4% of global GDP, then what we're doing is of value, or should be of enormous value, and clearly there should be more of it. The scoping review of economic interventions was the overall rating of the economic studies was of low moderate quality. Focus on guess what cost savings. My colleagues also concluded that economists and health economists have not paid this OH area sufficient attention. They think it's hugely important, but the economic studies were pretty poor. Next slide. So the qualitative study, we were limited. We could only do one round. Was UK academic experts, some of whom will be here, I suspect. International academic experts, 2 OH providers, employer organisation representatives, and government representatives, and that was the classical qualitative study. Now, the recommendations that we came out with in the report were requirements for a new centre. So that we weren't just doing a critique of literature; we were drawing inferences from it and paying attention and coming out with recommendations which were actually focused on actions where possible. So this was first proposed by Carol Black. So looking for a coordinating body in the UK to provide leadership knowledge, facilitate translation, and to grow and support the academic base. That's since been adopted as an objective by the Multidisciplinary Academic Forum for Health and Work, which I chair. And the project has since been developed by colleagues in the Work and Health Unit, and I understand a proposal is going to the DWP Investment Committee as we speak. And it remains to see whether this is funded. So that recommendation has led to action. The centre, the academic forum view of a centre, it should be agile, it should be semi-virtual, it should be network, It has to be multidisciplinary. It should have public and patient worker participation. It must fit a devolved nation structure. It should have stakeholder, body, industry, employers, HR, worker representation, and be strongly social media communications. So that's the vision that the Academic Forum has developed that objective to. A national coordinated research strategy. 3 was urgent action to retaining and building the academic base. We've lost, in my time I've been doing occupational health, we've lost 6 funded occupational medicine chairs in the UK which have not been replaced. And virtually it's all disappeared like snow off a dike. However, Colt have just launched their clinical academic fellowships, and there are other things in the pipeline. So improved dissemination and marketing to promote value to key stakeholders. Whatever we like, whatever we think about a human right, I think it is a basic human right. Actually, we have to be perceived as of value. To identify current research priorities of employers, HR and workforce representatives. So continually to find out what our people are looking for. Next slide, please. Technology coming across quite strongly from some of the qualitative and other people. Integration of technological advances, more innovative technologies, database development, social media and artificial intelligence to understand better the health and functional capabilities of people and what we can do to improve it. We need to be much more forward thinking and cutting edge in terms of how we do epidemiology. Next, high quality economic evaluation studies to help decision makers make best use of resource. Whatever we like to think, people will always come back to what does it cost and what's the return on investment. And I can produce legions, some of which have been published, things where there's been a positive return on investment. And most of our colleagues, if they're involved in looking at data, can demonstrate that. But these should include, this is the recommendations of the qualities, yes, cost benefit, yes, ROI, yes, but cost consequence analysis as well. Next slide. There was the third one was there needed to be funding and investment in OH research from government, employers and industry. And additional recommendations, as you might imagine, if I had anything to do with it, was there should be universal access to occupational health for the working age population, not for workers, for the working age population, because there's a lot of people fall out of work and they can't get back in. And to increase the occupational health resource. So that, next slide. So the launch was very important. It was led by David Blunkett at the House of Lords. It was attended by about 30 people, research councils, HSE, FOM, SOM presidents and senior figures in organisations. I presented the report verbally. The next week, Nick was phoned up by Pahl Nightingale, who's the Director of Strategy of ESRC, to say, this is what we have been waiting for. These were his very words. And then he proactively coordinated MRC, ESRC and other funding councils to set the whole ball rolling, which is ongoing. And so these reports are really important, are valuable. And what has helped in this situation was Pahl Nightingale proactively contacting SOM and to Nick to say, what can we do more to make some of this happen? So thank you very much.
Thanks, Ewan. Sorry, I was kind of driving those slides to be on time, but I mean, this is what we want, is to have the research, isn't it? Backs up occupational health. Obviously, independent research, it could go either way, but you've been, absolutely legendary, Ewan, in terms of driving it forward, and with this research, Value of Occupational Health Research Report, which I'll put in the chat too, has been instrumental to that too. But I suppose today is also about encouraging people to, in their work, to carry out research to build on the value proposition report that Paul's pulled together. Any quick questions before I look for where I think Mary from Ansom is going to be presenting, and hopefully Nick can make sort of be able to present. But any quick comments? Okay, Mary, are you there? All the way from Australia, New Zealand? Not sure if you are. Or any colleagues from ANZOM? That's unfortunate. I was expecting Mary to join us. Let's have a look. Okay, well, I might send you an email, and yeah, we all owe you a drink, Ewan, so you can be drunk for the next month, hopefully, or more. Any sort of comments or questions? I can see various colleagues from Linda Bruce up in Scotland and Steve Mallison, Doreen Miller, who's been fantastic talking about the value of occupational health and the marketing side. Lan Ray as well. Any comments? And then we've got ENS and Ephantis from to be picked up across the. I know there's been a lot of work there too. No. Stun people into silence. Paul, any final comments from you? Oh, here's Ianis. Welcome, Ianis.
Yeah. Hi, I have some connection issues. I don't know, my camera is not working.
We can hear you, yeah.
Okay. Great to participate in this event. Indeed, the pandemic has highlighted all those important issues, and it is really important to highlight this kind of also interface between public health and occupational health. I fully agree with the concerns that Professor Macdonald expressed in his presentation, and I'm really glad to participate in this.
Thank you.
Thank you. While we're waiting, I'm sure they're going to join us, Nick. Just one of the things I'd like to say is that I think it was Paul's final comment about gathering. We do need to gather more of the anecdotal stories in terms of what has been done to change sickness absence, accident rates, attendance in organisations, and many people have got stories to tell about an intervention which has led to change. Doesn't mean to say it satisfies the science, but we do need to gather more of these case studies, if you like. But ultimately, we need more research, and there's a paucity of people doing research in this field, and therefore, for many people working away and doing interesting intervention or a change, they don't necessarily have access to somebody who will give them help, largely because of the lack of resource and the closure of so many departments related to occupational health, medicine and nursing across the UK.
Okay, I still haven't heard from Mary. I think we might have to hold it there. I mean, I know it is lunchtime as well, so people probably wants to go, but do stay in touch. Any comments on the report, welcome. I put the link in, which I think it was 2019 actually, not 2017, for the value of occupational health research. Comments from Pooja, there could be specific legislation, sports staff training at work as compulsory, and when the OH are considered nice to have, and I suppose it'd be nice to see employment law sort of focus on this. Looking forward to a new mental health strategy on this. And Richard Heron, I've never seen an ROI case presented. Why do we still think OH should need one, have one? But I think this has been a useful discussion in terms of focus on cost effectiveness. There is ROI there if people need it, the need for more research, but also clear benefit occupational health. So thank you for joining us today. Do use this as you see fit. Stay in touch in terms of any comments on the report. And thank you and have a great afternoon, and be in touch. We've got a neurodiversity, Commissioning Neurodiversity report launching tomorrow, so for Neurodiversity Awareness Week. So it's busy here, and I'm sure you are too, and hope you enjoy your lunch, and thanks for joining, and thanks to Paul in particular.